All right, let's dive right in. If you're prepping for your pediatric exams, you already know that childhood tuberculosis is a topic you simply cannot ignore. It's a guaranteed high-yield area. So, today we are going to do a deep dive, a masterclass on the concepts that show up again and again. We're talking Gons complex, Walgren's tabletop, and the big one, tuberculous meningitis. Let's get to it. So let's start with this puzzle, the central paradox that really gets to the heart of what makes childhood TB so unique. How is it that a child can have a very low number of bacteria, we call this paucibacillary, and yet be so incredibly vulnerable to the absolute worst, most widespread forms of the disease? It seems counterintuitive, right? Well, the answer is a dramatic race against the clock, playing out inside their still maturing immune system. So here's our game plan for today. We'll kick things off with pathogenesis, the why it all happens. Then we'll zoom in on the classic signature of infection, the primary complex. From there, we'll map out the disease's timeline using Walgren's table time, look at the clinical signs and its most feared complication, TBM, and then we'll wrap it all up with how to diagnose and manage it in the real world. Okay, Section 1, pathogenesis. This is the foundation for everything else. You really have to get this part. The key thing to remember is that when it comes to TB, kids are not just miniature adults. Their immune response is fundamentally different, and it's this difference that dictates the entire course of the disease. So let's follow the bug. Step 1, the child breathes in the bacilli. They get eaten by macrophages in the lungs. But, and this is the clever part, the bacteria basically hijack the macrophage. They prevent their own destruction and turn their predator into a safe house. This leads to step 2, and this is the absolute crucial window in children. For the first 3 weeks or so before the immune system is really woken up, the bacteria just multiply and multiply. This leads to a silent spread through the bloodstream, seeding bacteria in all sorts of distant organs, like the brain, bones, and kidneys. It's only after this, in step 3, around 4 to 8 weeks later, that the T cells finally get their act together, activate the macrophages properly, and start building granulomas to wall off the infection. And that's when the tuberculin skin test finally turns positive. So once that immune response kicks in, how does the body actually build that wall, the granuloma? For your pathology questions, here's a super simple memory aid that'll help you structure your answer perfectly. Just remember the rule of 2s. Let's break it down. At 2 days, it's pretty chaotic, just a rush of monocytes and macrophages to the scene. By 2 weeks, things get more organized. You start to see the classic Langhans giant cells forming, and that hallmark cheesy material, the caseous necrosis, begins to appear in the center. Finally, by 2 months, the structure is mature. It's walled off by a huge number of lymphocytes, and you have your classic, fully formed tubercle. So, 2 days, 2 weeks, 2 months. Easy, right? All right, now let's see what this process looks like on a bigger scale, the anatomical signature of primary TB. This brings us to Section 2, the primary complex. I cannot stress this enough. This is a guaranteed long answer question. You have to know the Gons complex inside and out. First things first, the definition. You have to be precise here for the exam. The Gons complex is not just the lesion in the lung parenchyma. It is the combination of that lung lesion and the involved regional lymph nodes. You have to mention both to get the marks. It's the whole package. And to really nail that long answer question, you need to list all 3 components. So number 1 is the Gone focus itself, that little area of consolidation usually right under the surface of the lung. Number 2, and this is the one people often forget, is the tuberculous lymphangitis. These are the inflamed lymphatic channels that act like highways, carrying the bacteria from the focus to the lymph nodes. You can't actually see this on an X-ray, but it is a key part of the pathology. And number 3 is the hilar or mediastinal lymphadenopathy, those big, swollen, caseating lymph nodes. Frankly, in kids, this is often the most dramatic and obvious part of the whole complex. And take a look at this. This is the classic picture. This chest X-ray shows it perfectly. See the bottom arrow? That's pointing to the Gone focus out in the periphery of the lung. And the top arrow? That's pointing to that huge, swollen hilar lymph node. When you see both of those, you are looking at the radiological signature of a primary complex. Now, here's a quick point of clarification that often trips people up. Gons complex is the active infection. When the body gets it under control and it heals up, leaving behind fibrosis and calcification in both the focus and the nodes, it's then called a Ranke complex. So think Gons is active and inflamed, Ranke is old and calcified. Okay, on to another absolute classic, something you will almost certainly be asked about, Walgren's timetable. This is more than just a historical concept. It's an incredibly useful framework that lays out the predictable sequence and timing of TB complications after that initial infection. It's the natural history of the disease, mapped out. This timeline is pure exam gold, so let's walk through it. The first 6 weeks, that's your incubation period. But look at this next window, 1 to 3 months. This is the danger zone. This is when that early silent spread can manifest as the most life-threatening forms, miliary TB and tuberculous meningitis. After that, from 3 to 12 months, you tend to see more local problems, like those lymph nodes getting bigger. Later on, between 1 and 3 years, you might see skeletal TB pop up, like Pott's spine. And then way down the line, more than 3 years later, you can get the really late stuff, like renal TB. And this quote really drives the point home. The clinical importance of Walgren's timetable is that it tells us why we have to be so aggressive with diagnosis and prevention in young kids. We are literally in a race against this predictable clock. We have to intervene before that 3 to 6 month window closes to stop those catastrophic complications like TBM. So let's connect all this theory to what you'll actually see in the clinic. Section 4, the clinical spectrum. We'll talk about why pediatric TB can be so sneaky and hard to spot, and then we will do a deep dive on its most devastating complication, tuberculous meningitis, which is a full-blown neurological emergency. This table, you should basically just memorize it. It's a very common exam question. The biggest takeaway? Kids get a pauci-bacillary primary disease. They have very prominent lymph nodes, and it often spreads outside the lungs. This means they aren't very infectious to others, but it makes them incredibly hard to diagnose. Adults, on the other hand, usually have a multibacillary reactivation disease with cavities in their lungs. This makes them highly infectious, but it's also a lot easier to get a positive sputum sample. So, how exactly does TBM happen? It's not what you might think. The bacteria don't just directly infect the meninges from the bloodstream. The critical concept here comes from a pathologist named Arnold Rich. He figured out that during that initial silent bacteremia, tiny little granulomas, or rich foci, get seated in the brain or on the meninges. TBM happens months later when one of these little time bombs ruptures, spilling a massive load of TB antigens into the cerebral spinal fluid and triggering a devastating inflammatory storm. And that brings us to another absolute exam favorite, the clinical staging of TBM. Stage 1 is the real trap. The symptoms are so vague, a little irritable, maybe a low-grade fever. It's so easy to miss. By stage 2, you start seeing the hard neurological signs: neck stiffness, cranial nerve problems. And in stage 3, while the child is in a deep coma with profound neurological damage. The reason we care so much about this staging is that the outcome is completely tied to the stage of diagnosis. If you catch it in stage 1, the kid can do great. If you wait until stage 3, the prognosis is just awful. So what does that inflammation actually do to the brain? It causes 3 main types of damage. First, the thick, sticky exudate at the base of the brain blocks the flow of cerebral spinal fluid, causing hydrocephalus. Second, that same gunk coats the cranial nerves, leading to palsies. And third, it inflames the blood vessels, causing vasculitis and strokes. You put all that together, and it's why survivors are often left with severe, permanent neurological problems. All right, let's get practical. We've covered the pathology and the clinical features. Now, how do we actually put this all together to make a diagnosis and manage these kids? This is our final section, and it's all about a systematic clinical strategy. This flowchart right here is straight from the national guidelines. I know it looks a little intimidating, but this is your roadmap. It guides you through the whole process. So to make it easier, let's just break it down into the 5 key steps you'll follow. So it always starts with clinical suspicion. From there, your first step is a good quality chest x-ray. Now here's where the path forks. If that x-ray is really suggestive of TB, you move to step 3. You go after a specimen, a gastric aspirate or induced sputum, for a rapid molecular test, like a NAT. But if the x-ray is kind of inconclusive, you might go to step 4 and try a course of appropriate antibiotics. And this leads to the most important step of all, step 5. Let's say your fancy molecular test is negative, but you still have a really high suspicion based on the clinical picture. The guidelines are crystal clear. You treat. You label it clinically diagnosed probable TB. This concept is absolutely vital in pediatrics, where waiting for microbiological proof just isn't an option sometimes. And finally, management. For simple, uncomplicated pulmonary TB, you're looking at the standard 6-month course. But for the severe forms like TBM or miliary disease, you absolutely have to extend that therapy out to 9 or even 12 months. The other life-saving intervention for TBM? Corticosteroids. They are non-negotiable. They are there to dampen that destructive inflammatory response. And please, never, ever forget contact tracing. Every single child with TB is a canary in a coal mine. There is an infectious adult somewhere in their life, and it's our job to find and treat them. Let's wrap up with a perfect Viva question that ties everything together. Why do we use steroids in TBM, but not in straightforward pulmonary TB? Here's your answer. In TBM, the real enemy isn't just the bug, it's the body's own over-the-top inflammatory reaction. The basal exudates, the vasculitis, that's what causes the brain damage. Steroids directly attack that inflammation. In uncomplicated lung TB, the damage is more directly caused by the bacteria, and tamping down the immune system isn't helpful. If you can explain that, you're showing the examiner that you don't just know facts, you actually understand the disease.